Hello, everyone, and welcome to today's Present Approaches to Testing webinar on Advancing Immunosuppressive Therapy in Solid Organ Transplantation, Integrating Pharmacogenomics, Therapeutic Drug Monitoring, and Precision Medicine. I'm Dr. Linda Hisatsri, the Director of the Molecular Technologies Laboratory and a consultant in the Division of Laboratory Genetics and Genomics at Mayo Clinic in Rochester, Minnesota. And I have the pleasure of introducing our speakers today. So our presenters today are Adley Lemke, a solid organ transplant clinical pharmacist, and Jessica Wright, a pharmacogenomic pharmacist, and one of the faculty for Mayo Clinic's 16-hour online pharmacogenomic certificate course titled Integrating Pharmacogenomics into Clinical Practice. Both presenters are from Mayo Clinic in Rochester, Minnesota. Just a couple of reminders for folks before we begin today. There will be a question and answer session at the end of the program, and so you can submit your questions via the Q&A icon in the bottom right on Zoom. Please only use the chat function for any technical issues. Today's program is being recorded and will be posted to our website in a few weeks. And with that, I'll now turn things over to our presenters.
Excellent. Well, thank you so much for inviting us. And we're absolutely delighted to be here to talk about integrating pharmacogenomics into solid organ transplant therapy optimization. To start our talk off, I just wanted to state that neither I nor Dr. Wright have any disclosures to provide. Our learning objectives today are going to be learning about the significance of pharmacogenomics and therapeutic drug monitoring coupled to optimize immunosuppressive therapy for non-liver transplant recipients. We're going to talk about common pharmacogenomic variants and key ones affecting immunosuppressive drugs, and apply a structured approach to patient care that integrates pharmacokinetics, pharmacodynamics, and pharmacogenomic data in the management of drug-drug, drug-gene, and drug-drug-gene interactions. So stay tuned, it's going to be exciting. To start things off, I always like to put things in context of a patient case. So I'd like you all to meet Jonathan. Jonathan is post-operative day 1 from heart transplant, and our team informs us that it's time to start tacrolimus, azathioprine, prednisone, valganciclovir, trimethoprim sulfamethoxazole, rosuvastatin, and pantoprazole as part of the post-transplant regimen. Now, we do have pharmacogenomic data for Jonathan. All of that is listed on the slide here. And what I want to highlight is his poor metabolizer status of 2B6, his ultra-rapid metabolizer status of 2D6, and then he's a normal metabolizer of 3A5. So the question is, do we need to adjust our approach to dosing? So we're going to start off with some background, and with that, I'm going to transition the slides over to Dr. Wright.
All right, thanks very much. Well, what is pharmacogenomics? It is the genetic influence on drug response. And there's many factors that do influence drug response. So typically as pharmacists, we'll think about kidney function quite classically, but also age, sex, weight. There's plenty of drug interactions that we think about as pharmacists as well for drug response, liver function, and many others, environment as well, food interactions. But genetics is another factor that influences drug response. So I like to think of a pharmacogenomics interaction as similar to having a drug interaction since birth. So in this manner, some genetic variants can potentially impact the patient throughout their life for whatever medications may be either metabolized through those pathways that gene affects, or it could be through receptors or various other mechanisms. But we've done some studies on pharmacogenomics and adverse drug reactions. So we know theoretically that this should probably impact that, but there's actually been some really fantastic studies that are randomized controlled trials that have shown a dramatic decrease in the drug reactions of medications. And we also know that there is an increase in efficacy of certain drug regimens when we use pharmacogenomics to determine the drug dosing or choice of drugs. Next slide. Right. And why would we want to perform pharmacogenomics testing? Well, our genes don't change, but the lab tests can improve over time. So the test results can last many, many years or a lifetime, but the lab tests, as they improve in the future, as the testing gets more advanced, there is a potential that patients may want to get another testing done, maybe 10 years down the line from when they first got their test or so. But there's no specific guidance per se. That may be up to clinical judgment. But there's a low risk of the test. It's non-invasive. Usually it's a saliva swab, although it can be a blood test as well. And it can guide many different medications. So most of the, I'd say, medications that are guided by pharmacogenomics testing tend to be like CYP enzymes, which would be cytochrome P450, and those are enzymes that metabolize many medications. But there are many different genes that are tested in panel tests, and there's a lot to choose from. And we have guidelines, which are usually called CPIC. So CPIC is a very common guideline, which stands for Clinical Pharmacogenomics Implementation Consortium. And then we also have some smaller studies or some theoretical level evidence that would be similar to something like a drug interaction that could be considered. And so there's a lot of potential for guidance of many different medications. And the nice thing about what we've done in terms of our scientific community in pharmacogenomics is there's cost effectiveness studies that have been conducted in many different settings. And it's shown to be cost effective in many settings, ranging from psychiatry to oncology to just general polypharmacy. But one thing I wanted to note as well is that panel testing can be more cost effective than single gene testing, because typically the costs are likely about the same, and just due to, I think, how the laboratory runs the test. But also good news, recently, a couple of months ago, Medicare has been, in certain states have been actually, approving pharmacogenomics testing and having that covered. And so that was a big win for many states that have the Medicare in those areas, especially, Minnesota, Wisconsin, Illinois. So that's been really nice to see. But I think insurance varies. So that's another kind of aspect to consider about pharmacogenomics. And many people do have questions about that. But that was a positive development to see. Next slide.
So now I'd like to make the case for why we should test pharmacogenomics in our solid organ transplant recipients. There's a few different reasons. The first is polypharmacy. So the average number of medications that patients are on after transplant exceeds 12, which means there's an increased chance that the pharmacogenomics tests will impact one or more of the medications these patients are taking. Additionally, when you have end organ failure, frequently that comes with a number of comorbidities. And we know that our transplant patients have a significant comorbidity burden, so there indicates that the genomics testing might be able to help some of those other treatments that are independent of, but inclusive of also their immunosuppression regimens. Relating to that, a lot of our patients are extremely vulnerable. And one of the benefits of genomics testing is that we can avoid adverse medication reactions frequently. And when we're avoiding one of those events that could have a pretty big impact on our patients' outcomes, that's a big win for precision medicine. Additionally, when I'm evaluating these patients in clinic, many, many times they report to me that they have numerous allergies or medication intolerances. And a lot of times those intolerances can be explained in part or in full due to their genomics tests. And we can provide more educated counseling and precise therapies to talk them, to work with them to identify medications that might be beneficial within the same class or a different class post-transplant. And lastly, our immunosuppression regimens and infection prophylaxis regimens have numerous drug interactions. Knowing the pharmacogenomics tests and integrating those drug interaction knowledge can help us navigate a little bit more effectively of what therapies and drugs and doses would be right for our patients. Now, key to all of this is when to test. I would argue that testing prior to transplant is the ideal time because that moment of transplant is when we're going to have the highest number of medication changes and medication regimen setups. And having that genomic information available at the time of setting those regimens is key to successfully incorporating that information and avoiding any unnecessary adverse medication events that might occur. So in summary here, pharmacogenomics offers high value to solid organ transplant recipients, and I will argue that until my breath runs out. With that, I'm going to transition back to Dr. Wright to talk about one notable exception in solid organ transplant recipients, which is transplanting the liver.
Thank you. So the liver transplant situation does complicate things because patients who are born with a particular liver and then have that changed out in an organ transplant and receive a donor liver are not going to have the same genetic test results that would come from blood or saliva, which really tests like a white blood cell type of DNA, and that is not going to be matching their new liver DNA. And the liver is where we have medications that are processed. However, if we have some genes that have, expression and consequences outside of the liver, in that case, we would want to use those test results. So a lot of these genes that are tested are typically the cytochrome P450 genes. We have genes like SLCO1B1, UGT1A1 that are really expressed in the liver. So it's really important to think about the expression of those genes, where it matters. Is it a drug metabolizing enzyme that's going to be in the liver versus like a gene like an HLA, which an HLA gene confers a skin reaction, and those consequences occur in the skin, and it's not because of a liver metabolism issue. Similarly, with a gene called G6PD that's tested in the red blood cells, and the consequence of a drug gene interaction with that occurs in the red blood cells. And so those are two kind of exceptions to the exception, as I'd like to say, with this. So just really know that, especially when we're talking about CYP enzymes, if the patient had a liver transplant and other genes that are metabolized and expressed in the liver, you don't want to be really relying on those results or get pharmacogenomic testing for those results, because it's going to be a mismatch for that patient. And then I'd like to turn it back over to Adley.
All right, let's talk about designing immunosuppression regimens. So when we're thinking about the patient in front of us, we're doing a risk-benefit assessment with each of them, looking at their risk of rejection versus their risk of complications from immunosuppression. So we know that as we increase immunosuppression, our rejection risk decreases significantly and proportionate to the amount of immunosuppression. However, we have to balance that with the fact that immunosuppression increases our risk of medication toxicity, infections, and cancer. And so we're always looking for this sweet spot of where exactly does the patient need to, amount of immunosuppression the patient needs to optimize and balance their risk of rejection with the specific donor they've received and their time from transplant and their immunosuppression burden. Now, what makes this difficult is it's a moving target with time after transplant, and it also is individualized per patient to figure out what their specific risk of rejection is in order to balance these weighing factors. So we're already doing quite a bit of precision medicine in the field of transplant. And what that currently looks like right now is therapeutic drug monitoring. So what is therapeutic drug monitoring? Well, essentially what we're doing is we know that our patients don't have a predictable dose response necessarily to medications we provide. A classic example is tacrolimus, which is one of the backbone immunosuppression agents we use. We know that there's significant variability in between individuals of what dose they take of tacrolimus and the overall drug exposure that they have as a result of that dosing. So what we do in clinical practice is we get trough levels. Essentially, we're drawing a drug level right before their morning dose of tacrolimus, and we're going to use that trough level to estimate their overall drug exposure or their area under the curve, essentially looking at how much of that drug concentration is in the blood over time during that dosing interval. And we adjust the dose based off of those trough levels in order to achieve an ideal overall drug exposure for the patients. Now, I have an image here that's extracted from the Symphony study, which is one of the landmark clinical studies used to guide immunosuppression dosing in kidney transplantation. What they did is they had a set tacrolimus dosing regimen for low tacrolimus levels, guiding us to target between 3 and 7 nanograms per milliliter. And what you can see in the study is they reported the overall drug concentrations with patients over time and compared it to that goal range that they were aiming for. And what you can see is that even with set dosing intervals and a set dosing regimen, those error bars indicate there was significant variability between patients in terms of how we achieved those levels, even when we had those set level goals and even when we were utilizing therapeutic drug monitoring. And part of that variability can be explained using their pharmacogenomics, which we'll get into a little bit later. Now, let's talk about operationalizing pharmacogenomic testing into a solid organ transplant practice. So to do this, I have to recognize that everyone's practice is a little bit different and everyone has a different flow of how they do things. So what I'd like to describe here is how we've integrated pharmacogenomics in our solid organ transplant practice in order to see if there's something that could benefit you all. So the first step is, like I explained earlier, to include the test in the pre-transplant evaluation phase. This is for a variety of reasons. One of the reasons is cost. So we know that pharmacogenomics costs can be a barrier to utilizing the test. However, if we say it's a standard of care of our institution, we can bundle that test with the other laboratory markers that we're gathering to do our pre-transplant evaluations and use that in the cost bundle overall. That way, it's a little bit easier. There's less of a barrier to talking patients into it. And we have those lab values available at the time of transplant to use in incorporating and designing our post-transplant regimens, which is very wonderful. Now, we recognize that there is a gap between the time that a patient's evaluated for transplant, listed, and then gets a transplant itself. In some cases, like in kidney transplant, that can be years later. And so what we wanted to do is incorporate a pharmacogenomics consultation with one of our pharmacogenomics pharmacists, like Dr. Wright, in order to evaluate the tests at the time it results to see if there's anything actionable at that time for the patient so that there isn't a gap in interpretation or there isn't something that we could have optimized a little bit earlier. Next, we'll have the patient present for their transplant itself. And at this time, our team of transplant pharmacists is doing a subsequent comprehensive pharmacogenomic and medication review to see if there's anything currently active on the med list that we're going to continue at the time of transplant that we need to incorporate some pharmacogenomic knowledge of and adjust. And then also think through our regimen changes that are going to be included at the time of transplant and incorporate pharmacogenomics adjustments then as well. Then we are going to use these genomics results in longitudinal care and optimization of our transplant patients. And what I want to emphasize here is two key things to successfully using these results. The first is multiple time points with set comprehensive pharmacogenomic evaluations, both when they're resulted and at the time of transplant, so we're actually using the result. And the other key thing is incorporating clinical decision support within our electronic medical record and creating resources that are readily available for our practitioners to use those results confidently. So now let's talk about what clinically significant drugs and genes there are and how we use them in our transplant practice. So at the time of pharmacogenomic evaluation at the time of transplant, there's several medication classes that we know we're always going to be using in our transplant patients. Those include immunosuppression, such as tacrolimus and azathioprine, our antimicrobials, particularly our azoles or voriconazole. Pain management is always something we're optimizing after a major surgery like transplant. Frequently, our patients are on psychiatric medicines, which all have an abundance of pharmacogenomic recommendations. We think about it with our anticoagulation selection, if for patients on warfarin in particular. Statin therapy, we're always looking at our genomic results and making adjustments if needed. And then any past medical history, so looking at those allergies and intolerances to see if any of them can be explained by genomics, and then making thoughtful selection of medications going forward using all of this data together. Now, this slide here is an outline of pharmacogenomic therapeutic drug classes that we talked about, with a few additional ones, and drug gene pairs that have clinically significant results in actionable pharmacogenomics. Now, I'm not showing this slide to overwhelm, but just to instill and emphasize how many drugs have pharmacogenomic recommendations attached to them, and knowing the number of drugs we're prescribing to this vulnerable patient population, the likelihood that we're going to have something to act on is high. Now I want to focus on CYP3A5 and tacrolimus dosing, and with that, I'll transition it back to Dr. Wright for some background information.
All right, thank you. There's many drugs that are metabolized by CYP3A4. And CYP3A4 is one of the most common drugs, I think, or the most common enzymes that people will think about in terms of drug metabolism. But CYP3A5 is also very important because many drugs, although they're metabolized by CYP3A4, there are some drugs that are significantly metabolized by CYP3A5. So most of the time, CYP3A4 steals the show. It's the main enzyme that takes care of metabolism. But there are some that I wanted to point out. So tacrolimus, diltiazem, testosterone, progesterone, nifedipine, and midazolam are among the drugs that have significant CYP3A5 metabolism. And so for tacrolimus, that's of course what we'll be focusing on with regards to transplant immunosuppression. But that medication is particularly sensitive to CYP3A5 expression. And I wanted to note that this is pretty different in various ancestry groups. So it's the CYP3A5 expression is highest in African ancestry, followed by Asian ancestry has some CYP3A5 expression, and it's lowest in Europeans. So in the European ancestry group, it's generally around only about 15% of those patients will be expressing CYP3A5. So CYP3A5 poor metabolizers are the predominant phenotype. And likewise, many medications are dosed based off of CYP3A5 poor metabolizer phenotypes. And so it's important to remember that if you have a patient with a CYP3A5 poor metabolizer test result, generally for most medications, there's not going to be any different dosing regimen that you'd have to think about. So for example, like diltiazem or midazolam, no dosing changes for the CYP3A5 poor metabolizers. Next slide.
All right, so how do we use the genomic data to actually dose tacrolimus? Well, I wanted to adapt this figure from tacrolimus therapeutic drug monitoring guidelines that had some very specific and actionable recommendations. Essentially, what they start out by saying the standard dose for tacrolimus is 0.15 milligrams per kilogram per day for most individuals. Of course, we have to modify that for which organ is transplanted and transplant-specific protocols, but in general, that's an accurate estimation of the average dose of tacrolimus. What they outline is that the CPIC guideline recommendations for poor metabolizers of 3A5, so most of our patient population, are going to get that standard dose. Then for intermediate and normal metabolizers, the CPIC guidelines recommend 1.5 to 2 times the standard dose, up to 0.3 milligrams per kilogram per day to start tacrolimus dosing. Now, the therapeutic drug monitoring guidelines add in a level of knowledge incorporating CYP3A4 star 22 and say that those that express 3A5 poor metabolizer status and 3A4 star 22 are going to be even more sensitive to tacrolimus. And so a lower starting dose of 0.14 milligram per kilogram per day is recommended. And I can tell you in clinical practice, when looking at the two combination together, these patients are ultra sensitive to tacrolimus dose increases in terms of what their level response is. Then they say for poor metabolizers of 3A5 and 3A4 normal metabolizers, they should get a little bit higher of a dose of 0.2 to 0.25. So a little bit higher than the average standard dosing for most folks. And then just like with the CPIC guideline, they say 3A5 intermediate and normal metabolizers should get much higher doses. And they even go so far as to say 0.3 to 0.4 milligram per kilogram today, which is equivalent to a 200 to 250% dose increase from that standard. Now, when incorporating this into clinical practice, a lot of times we're not dosing based off of weight, or our goal is not to get to tacrolimus goal immediately. But what you can do is take this genomic information and modify your tacrolimus protocol that's for those poor metabolizer patients and say, hey, this person's probably going to need twice that much or 1.5 times as much, and maybe start at a little bit higher a dose and use higher doses for escalation in those that actually express 3A5, again, being more of the minority of our populations being 3A5 intermediate and normal metabolizers. So what type of data out there is going to implicate tacrolimus genomic information available and clinical outcomes? So I wanted to start by talking about tacrolimus variability and rejection risk. Now, this is a study from Siebert and colleagues of about 1,500 kidney transplant recipients. And what they looked at is the rejection-free survival. So did you have rejection after transplant? And sorted things into those that were zero loss of function alleles, meaning they were normal metabolizers, being indicated by the solid line on the graphics. Those with one loss of function alleles, or intermediate metabolizers, indicated by the dashed line on the graphics. And then two loss of function alleles, which would be poor metabolizers, indicating a majority of our population as the light gray line on the chart. What you can see is that our patients that had zero loss of function alleles, or our normal metabolizers, that solid line, had a lot higher incidence of rejection compared to our intermediate and poor metabolizers. So that tacrolimus genomic information indicated that they would have a higher risk of rejection. And the authors went so far as to control for variability in the tacrolimus dose and saw that each loss of function allele itself was associated with an 84% lower hazard ratio of acute rejection, which is significant when we're talking about outcomes in our transplant recipients. I'll note I focused on figure A here, which was isolating those of African ancestry. When they looked at those of European ancestry in their patient cohort, figure B, there wasn't a high enough percentage of folks in that normal metabolizer status. There was only 6 people to make meaningful comparison of their outcomes. But then those in African ancestry, you see a huge difference there, which is a population where 3A5 is expressed more prominently. All right, now we talked about the genomic results and some clinical outcomes. Well, what does that mean in terms of tacrolimus target attainment and therapeutic drug monitoring when we integrate that with our 3A5 assessment? This was a wonderful study done in pediatric kidney and heart transplant recipients, where essentially the study monitors looked at their protocol for tacrolimus dosing over time and compared time and therapeutic tacrolimus range for our expressors of 3A5 and our non-expressors of 3A5. What they found was in that 0 to 90 days post-transplant, there was a significant difference in the number of patients that were in the therapeutic range between our non-expressors and expressors, with expressors having a lower proportion of patients in the tacrolimus therapeutic range compared to the non-expressors. Over time, that difference leveled out between the two groups, which was what we would expect when we're adjusting doses to tacrolimus levels. Over time, you get an idea of what patients need in order to achieve their levels, and you're making proportional dose adjustments over time based off of their baseline tacrolimus dosing. But I think what was significant here is that 0 to 3 months post-transplant is when we're at significant risk of rejection, and that is when we're having significant differences in our time and therapeutic range with tacrolimus when looking at expressors and non-expressors. The authors then looked at rejection outcomes and coupled that with de novo donor-specific antibody-free survival to say, okay, so did this time and therapeutic range affect these rejection outcomes and donor-specific antibody production? And what they found is that the expressors of 3A5 had higher incidences of rejection and donor-specific antibody production compared to the non-expressors, even when we differentiated those that had time in therapeutic range less than 35% versus more than 35% within each subgroup, which was clinically significant. I think implies that we have some room to grow in terms of our tacrolimus dosing, even when incorporating these genomic results. So let's think about toxicity with tacrolimus and what that means in terms of our dosing. This was a really fascinating study where the authors looked at 304 kidney transplant recipient biopsy results, and were specifically looking at tacrolimus-associated calcineurin inhibitor nephrotoxicity, a form of irreversible nephrotoxicity that affects morbidity after transplant and long-term survival outcomes of our patients as they progress towards CKD stages 4 and 5. What they found were patients that had higher tacrolimus dose requirements tended to have a greater percentage of calcineurin inhibitor toxicity on their biopsy results. And when they looked at the patients with genomic types available, they found that the CYP3A5 star1 genotype and additional corticosteroid therapy were independently associated with the development of biopsy-proven tacrolimus-associated nephrotoxicity. So what this is telling us is that our patients with CYP3A5 expression, those intermediate and normal metabolizers, have higher rates of rejection and donor-specific antibody production, but also have higher rates of calcineurin inhibitor-associated nephrotoxicity. That's not to say these patients shouldn't receive tacrolimus, since that is a standard of care, but perhaps we should increase our monitoring of these patients for rejection as well as calcineurin inhibitor nephrotoxicity, so that we can make modifications to their regimen should we detect it early on and improve their overall transplant outcomes. With that, I'm going to transition it back to Dr. Wright to start talking about NUDT15 and TPMT with azathioprine dosing.
All right, thank you, Dr. Lemke. So for TPMT and NUDT15, I wanted to talk about what exactly those particular enzymes do. Well, they detoxify 3 different types of medications, which is azathioprine, mercaptopurine, and thioguanine. Collectively, these 3 medications are known as thiopurines. And TPMT function and activity can be assessed by either genetic testing or biochemical testing. Well, genetic testing is an interesting type of testing because you want to really be considering the ancestry prevalence for TPMT when using this test, because Europeans and folks of African ancestry, they have typically the most TPMT variants, right? So NUDT15 is a gene where it's not really that common compared to some other ancestries. And so that would be Asian and Hispanic ancestries and ethnicities that express more of the NUDT15 deficient or decreased function variants. So it's very important to test those 2 genes together because we don't want to be missing one or the other. And especially if we have patients of Asian descent, we want to make sure, or Hispanic ethnicity, to be getting the NUDT15 testing. And TPMT biochemical testing is pretty interesting because it can detect the, an increased TPMT function. Perhaps it might be due to environmental reasons, or if there's, a particular part of the gene that we cannot test with the genetic testing that produces increased function. That can be tested with biochemical testing. Genetic testing cannot really detect any increased TPMT function. So that is a unique aspect about the biochemical testing. But the TPMT biochemical testing cannot detect any NUDT15 genetic variants or any kind of influence that NUDT15 has on the thiopurine toxicity. So I would definitely advocate for having both the genetic and the biochemical testing for TPMT and NUDT15 to detect, that full spectrum. Of note, there is no NUDT15 biochemical testing, just for TPMT. Next slide. All right. So when I mentioned some environmental factors, and there's a couple other factors really that affect TPMT enzyme activity, I wanted to go over really which groups have higher activity so that you can remember this. So males have higher activity, smokers, folks who are younger have higher activity, and also having exposure to thiopurines, azathioprine, mercaptopurine, thioguanine, is going to be increasing TPMT activity because the liver has enzyme induction, which means it just produces more TPMT after exposure to those drugs. But there are drugs that decrease the enzyme activity. So that would be methotrexate, sulfasalazine, and 5-aminosalicylic acid, especially in our patients with irritable or inflammatory bowel disease that might be taking those medications, or rheumatologic conditions. That's important to keep in mind. And that decreased activity would not be detected by genetic testing. That would be detected by the biochemical testing. Furosemide is thought to decrease activity, but the clinical significance is unknown, and there's not a whole lot of studies on it. So another common drug to really watch out for in terms of that interaction. Next slide. Right. So dosing is a little bit complicated based on TPMT and NUDT15, and it also depends a little bit on the dose adjustments. Recommendations are dependent upon whether or not we're using these drugs for oncology or non-oncologic reasons. But because we're talking about transplant, I'll talk about the transplant reasons for using azathioprine and those dosing recommendations. So for TPMT or NUDT15, based on the genetic metabolizer phenotype, normal, we'd use normal starting doses. If a patient's an intermediate metabolizer of either genes, then if the normal starting dose is 2 to 3 milligrams per kilogram, we would reduce that starting dose. And the impact really matters, I think, more in terms of the toxicity impact if you're using higher doses, right? So if we're starting at like the 3 milligrams per kilogram per day, you're going to have, of course, a higher toxicity amount risk than using the 2 milligrams per kilogram per day. So there's a pretty wide range of a dose reduction of 30 to 80% of the normal dose in the CPIC guidelines. And so thinking about when you're picking a dose reduction in that range, if the normal starting dose errs towards that 3 milligrams, I think it would make a lot more sense to use a larger dose reduction than, if the starting dose is on that lower end of the range. And if a patient's a poor metabolizer, we want to be considering an alternative medication just because that risk of myelosuppression can be quite great, and that drug is just going to be sticking around a lot longer in the body. For oncology reasons, a lot of times there can be a very drastic dose reduction and the drug could still be used, but for transplant, probably best to be considering an alternative. So a couple of interesting rare edge cases would be if a patient's intermediate metabolizer for both TPMT and NUDT15. So there's not a lot of studies on this, but when there was a study on it, there was a trend that was observed for a lower tolerance to thiopurines than a patient who would be just intermediate metabolizer for just one of the genes. So there doesn't seem to be a combined effect when we have intermediate metabolizers of both genes. So they're probably going to be a bit more sensitive to that medication and not have as great tolerance for azathioprine, but still could likely use the drug. Well, in the case of patients who are hyperactive or have high TPMT activity that's found on a biochemical test, clinical response is less likely because they are going to be metabolizing the drug faster. And while you could give the patients higher doses to improve the response rate, there could be a higher buildup of the toxic metabolites. So toxicity in the liver would really be the concern here. And so you may want to be considering an alternative agent, but if you have to use azathioprine, really monitoring for hepatotoxicity with those higher doses is going to be key. Next slide. All right, so I'd like to talk a little bit about how pharmacogenomics can be integrated into clinical practice. All right. Well, when we think about gene interactions, we also have to consider drug interactions and put that together. So when we're thinking about a gene-drug interaction and a drug interaction again with that, that's called phenoconversion. And so phenoconversion is an interesting phenomenon, where we don't want to just take the genetic result at face value. We need to be looking at these drug interactions too. So there's been a couple of studies on this, and it's pretty interesting to see what actually happens when we look at different genetic phenotypes, and then we give patients strong inhibitors or moderate inhibitors. But there's one study that looked at rapid metabolizers, normal, and intermediate. For the rapid metabolizers, when they gave them a strong inhibitor, those patients ended up getting phenoconverted to mostly intermediate metabolizers. Although, of course, you can see there was 39% that were normal and 15% ended up being converted to poor metabolizers based on the testing that was done by these authors. And for normal metabolizers, when they're given a strong inhibitor, even more patients were converted to poor metabolizers, which makes sense because they didn't start off with the highest amount of CYP2C19 function. But if the patients were intermediate metabolizers and they were given a strong inhibitor, everybody ended up being a poor metabolizer after that. So it may be that there are, patients who are going to be more susceptible to drug interactions based on their original genetic phenotype. So this is going to be one other, reason that it's good to get pharmacogenomics testing because we can understand how sensitive and how susceptible certain patients would be to drug interactions. So it's really important to be putting all this together. Interestingly, the authors had concluded that patients are going to be more sensitive to the drug interactions with intermediate metabolizer phenotypes, but they seem to have a much wider swing and I guess conversion if they were rapid metabolizers. Going from rapid to poor is a pretty drastic change. But it's also important to remember too that if a patient's a poor metabolizer, maybe a strong inhibitor might not have as much impact in certain patients, right? So thinking about CYPs, right? CYP enzymes and UGT enzymes are pretty different. So CYP poor metabolizers probably don't have a whole lot of function, but for a UGT1A1 poor metabolizer, they have about 70% of their function. And so roughly knowing that, if we're giving a UGT1A1 strong inhibitor, that's probably going to have a bit more impact in that patient who starts out with about 70% of function and that gets further inhibited versus having very little to start with and giving an inhibitor probably is not going to do quite as much. So these are things to think about when you're assessing gene drug interactions. Next slide. Well, here's a guide that I wanted to talk a little bit about in terms of lack of studies. So if a patient's phenotype hasn't been studied with a particular drug combination, you could think about using existing information about drug interactions to kind of guide your thought process. It's not exact, of course, and there can be many different factors for the actual impact, but in the absence of any other data, this could be a particularly interesting guide to consider. So I'd want to just highlight the case of atomoxetine and CYP2D6 poor metabolizer guidance versus CYP2D6 strong inhibitor guidance. It's very similar. So normally we want to be increasing the atomoxetine dose after about 2 weeks for normal metabolizers, and that's the general recommendation. But for poor metabolizers or those getting strong inhibitors, we want to be increasing that and pushing that out to 4 weeks, not 2 weeks. So that's actually exactly the same in both recommendations according to the atomoxetine package insert. And I'd like to also talk a little bit about intermediate metabolizers and what that might mean too, versus the poor metabolizer. So moderate or a weak inhibitor might be roughly what you would look for in the drug interaction information for a drug if a patient's an intermediate metabolizer. And interestingly, I was going to mention a little bit about the FDA because they actually quantify what is the magnitude of the area under the curve increase based on what type of inhibitor it is. So if there's a weak inhibitor, the FDA classifies that as having an AUC increase of 1.5 to less than 2-fold, moderate is between 2 and 5, and strong inhibitors have greater than 5-fold increase in AUC. This doesn't quite correspond exactly to like, intermediate to normal, intermediate, or poor metabolizers, because it really depends on the drug too and how much that drug is metabolized by the enzyme. And so, I've seen even some poor metabolizers can have about a 2-fold increase in AUC, and intermediate can be somewhere between like 30 to 50% up. So that'd be like 1.3 to 1.5-fold increase in AUC. So, it could be a little bit different based on different drugs, but you can kind of get a rough idea. And you can look to that guidance as an idea. Next slide.
Thank you, Dr. Wright. So now I want to present to you my step-by-step thought process for how I evaluate and navigate drug interactions with pharmacogenomic data. Now, the first step I take is to know any clinically significant phenotypes on my genomic panel for my patient. I just list them out in a little sticky note next to the medical record. And then I look through their medication list and identify the drugs that have a significant metabolizing enzymes that might be on the genomics report. So for example, in the list on the top there, tacrolimus is metabolized by CYP3A5. That would be a significant connection to consider. The next step I take is to search for inducers or inhibitors that might modify dosing recommendations based off of the pharmacogenomics result itself. So looking to see if there's any modification we need to make based off of those drug interactions, essentially. And then I'm considering the net effect and the clinical significance overall. So in the picture on the right-hand side, this describes tacrolimus's metabolism throughout the body. And so as you can see, when you have a strong inducer like phenytoin present, that induces the production of CYP3A4 and CYP3A5. So essentially, we're getting a lot more of those enzymes out there metabolizing drug. And the net effect is that phenytoin is going to decrease tacrolimus levels. So based off of my pharmacogenomics response, even if I have a poor metabolizer in front of me, I know I'm going to have to dose it more like a normal metabolizer and increase the tacrolimus dose in order to get desired trough levels. Now, conversely, if I have an inhibitor present like itraconazole, that's not going to affect the production of our CYP enzymes, but the ones that are out there, it's going to inhibit their activity. And so the net effect is that we're going to have increases in tacrolimus levels. So for example, if I have a patient that is a normal CYP3A5 metabolizer that usually would require a lot higher doses of tacrolimus, if I have a strong inhibitor present, I'm probably going to give them more like standard or even less than standard tacrolimus dosing because of the extent of that inhibition. So let's go back to our patient case and apply these steps. So the first step is to note any clinically significant phenotypes. So we said 1A2 is rapid, 2B6 was poor, 2D6 was ultra rapid, and 3A5 was normal. Now, when I compare that to our medication list that we're prescribing after transplant, really the big significant one here is tacrolimus with our CYP3A5 genomic phenotype of normal, which is unusual in our general population. Now I'm going to investigate the list to see if there's any inhibitors or inducers I should be aware of. And what I'll say is there's none present right now. But as you all know, in transplant frequently, that can change with the introduction of our other prophylaxis agents. So now let's consider the net effect. So we know for 3A4 normal metabolizers that our general guidelines say you have to have a twofold increase in tacrolimus dose retirement are anticipated compared to our poor metabolizers. However, immediately after heart transplant, we know there's a significant risk of acute kidney injury, and tacrolimus is nephrotoxin toxic, often dose-related nephrotoxicity acutely. And so we might not want to be so bold as to just double our dose right out of the gate, depending on what they look like post-operatively. But conversely, if it's not a great match between donor and recipient's immune systems, lower tacrolimus levels can increase our risk of rejection. And so we might want to look at our other induction agents to see, are we protected from rejection with a very potent induction agent like thymoglobulin that's going to completely wipe out the system, where we can be a little bit slower in our dose escalations of tacrolimus? Or did we get no induction regimen and we're just using steroids and maintenance immunosuppression right away, where we would have an urgency to get that tacrolimus to goal in order to protect them from rejection in the acute post-operative setting? All of these things need to be considered. At the end of the day, I think the genomics results and this drug interaction guidance gives us a nice map. It tells us where we're at starting out, where we need to be depending on our tacrolimus goal, and a nice path for how to get there. And we can adjust that journey depending on our other clinical situations. But without that genomic information, we're kind of going into this journey blind. We know where we want to go, but we don't know the path or the direction we need to use for dosing tacrolimus in order to get there. And we can really optimize a patient's experience by accounting for all of these things in our immunosuppression plan management and development. So a few concluding thoughts for you all. The first is pharmacogenomics is one piece of the clinical picture. It's best to couple it with therapeutic drug monitoring and clinical responses and monitoring of our regimens to make sure we're optimizing all of our medicines based off of the genomic results and our patient in front of us. Solid organ transplant recipients are at high risk of adverse drug events and are prescribed many different medications, which makes them great candidates for pharmacogenomic testing and really people that would benefit from it. Tacrolimus is associated with significant intrapatient variability. CYP3A5 metabolism is an excellent tool to predict dose requirements and can help identify patients at risk of rejection and tacrolimus-associated adverse effects like nephrotoxicity. And the dose guided by pharmacogenomics decreases time to therapeutic levels, increases time to therapeutic range early post-transplant, and reduces the number of dose adjustments and monitoring required to stay within that goal range. And with that, I'd like to open it up to any questions from the audience based off of our presentation, and thank you for your time.
So this question is, I perform immunosuppressive therapeutic drug monitoring as part of my job. Can you explain why someone might be on more than one immunosuppressive drug?
I'm happy to take that question. So there's numerous reasons for that, one of which is what we evaluated a little bit earlier, looking at calcineurin inhibitor-induced nephrotoxicity or just acute kidney injury after transplant. A lot of times in those cases, we know that the tacrolimus is going to increase. I think I accidentally pressed mute, I'm sorry. Acute kidney injury. And so one of the strategies that we'll use is we'll say, okay, maybe instead of reaching for a level of 9 to 12 on our tacrolimus, let's take it down to something like 4 to 6 and add on a supplemental agent like sirolimus, also aiming for a low level, thinking that combined, there'll be more potent immunosuppressive agents together so that we're still able to get the benefits of each of them and prevent rejection effectively. But because we're using lower doses of each of them, we're having less medication-associated adverse effects. So a lot of times that's a strategy we use when we have folks with CKD after transplant. Another reason might be for someone that's having refractory rejection. So we're having episodes of rejection treating over and over again, and that person just needs a lot more immunosuppression compared to others. In those situations, a lot of times we'll add on other agents like those sirolimuses or everolimuses. I think the important thing when you're thinking about combining immunosuppression agents is that there's no situation in which we would use two medications from the same class. So we would never use tacrolimus and cyclosporin together because they do the same thing. You're not going to get added benefit. You're only going to get added toxicity. But sirolimus and tacrolimus, though they sound the same, they work differently, and therefore they have a more synergistic effect on suppressing the immune system.
If you do have a question that wasn't answered today, or if you have any additional questions that you think of later, please include them in your evaluation. You can reference the link in the chat to access the evaluation now. A reminder, laboratory credit is extended for this program, and so upon finalizing your evaluation, you'll have the option to claim credit and print your certificate. If you registered for this webinar and joined by phone only, please email us at mcleducation@mayo.edu if you do not receive the evaluation. And again, as a reminder, this program was recorded and will be archived on our website in a few weeks. Thank you again for joining us for today's webinar, and have a great day.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.